Hello, I'm Solomay Tibabu, the host of Going Digital Behavioral Health Tech. Really looking forward to this conversation with Dr. Andy Keller with us today from Meadows. Welcome, Dr. Keller. Could you help us with just some background and name, title, company?
Yeah, happy to. It's great to be here, Solomon. Thanks for including us. So I'm Andy Keller, and I do like Andy better than Dr. Keller because I feel like I get nervous when it's Dr. Keller, but I'm good either way. And I am the CEO and president of the Meadows Mental Health Policy Institute, and we are a Texas-based nonprofit, nonpartisan mental health policy and program research organization. Sometimes people think of us as a think tank, and I try to think of us more as a do tank, where we kind of go out and partner with people to see where there's policy or financing barriers to doing more effective things for mental health and substance use disorders. And then we go work on those with state, local, and federal officials to try to change laws, change rules, change processes. So we do a better job. And I'm a psychologist by training and licensed. So
Excellent. Thank you. So, Andy, you recently testified in front of the Senate Finance Committee on mental health. Could you tell us some key takeaways from that session?
Yeah, so the Finance Committee shares jurisdiction with the Senate Health, Education, Labor, and Pensions Committee, the Health Committee, over mental health parity. So the laws that really date back really to the Clinton administration, but got made broader under the Bush administration and under President Obama, that require insurance companies and health people providing health insurance in general to have the same level of coverage for mental health, the same approaches for mental health, and not discriminate against mental health as they do for other physical health disorders. So what they were looking at was what was our progress on that. And it was kind of fun because the Department of Labor, which has oversight of our large self-insured companies, unions, governments who provide insurance for their employees through third-party administrators, has started to enforce parity. So it's sort of like you've had the laws for decades, but enforcement really began last year. It got ramped up under President Trump, and then President Biden under Secretary Walsh. They started enforcing it. So that's what we got to talk about.
Fabulous. And what specifically do you think needs to transform in our healthcare system to really be able to address our country's mental health crises?
Absolutely, Sloan. And we kind of got into that, the sort of overlapped in the parity discussion with the committee, because the committee was sort of asking two things. One, are we on the right track with what the Department of Labor is doing? Because what the Department of Labor did was it came in and looked at the mental health benefits of the first several dozen companies, I think 50 something. And, but it was a lot. And none of them were meeting the parity requirements. All of them were basically providing less access to mental health in terms of availability of clinicians in their networks, in terms of the barriers they put in place before they would pay for something than they do for other physical health care. So that was their main question at the committee, but it's these larger structural issues you're talking about that I think were the problem. And we had a chance to talk about that. So, one of the things is that within these insurance companies, the mental health is managed it used to be by a separate organization. Now it's usually by a division of that organization, and they manage it not thinking about the rest of the healthcare. And so they don't think about primary care. And that's how we've gotten ahead of every other illness. I mean, one of the big reasons, the biggest, I would say, reason we've made year over year gains in mortality and morbidity for heart disease, cancer, is because we've embedded a lot of early detection and early treatment in primary care. And we haven't done that systemically in the US. So that was the biggest thing we talked about. I talked about how we do need to enforce and really hold these companies to deliver on the promises they've made to their beneficiaries. But that's not enough, because if we just keep hammering them to just say, make more specialists available, and we don't use primary care to help people, A, get access sooner, and B, get care there that works, because it works really well if you get depression, anxiety, other disorders early in primary care. and have the right supports. So I think I was really pleased because I thought the Senate kind of heard that we're not going to get anywhere just by beating up on insurance companies. We need to beat up on them a little bit, but we really need to look at how do we change these structurally. So that's one structural area, and there's a couple others, but does that make sense? Kind of as a main one.
Just a real quick question about that for those in the audience who might not be familiar. Yeah, of course, specialists are so limited at this point in time. And one thing that I know Meadows has focused a lot on has been around integrated care, but more specifically collaborative care. And yeah, leveraging PCPs in light of our resource constraints. Can you define collaborative care for those who might be unfamiliar? I know we want to talk more about this, but.
Yeah, no, I'm really glad, Sloan. That's a great question. So, integration in primary care has been a focus probably about 15 years. We've been talking about it, and we've looked at all sorts of different models, whether, we just co-locate therapists, whether we, practice more together. What collaborative care does, the collaborative care model, is it's the most researched and the most proven to be both effective and cost-effective model that's out there. And it's also been, there's been like 80 huge studies that have shown cost savings. The RAND organization last year did a big study in early 21 where they kind of did a meta-analysis and said there's like a 13-to-1 savings because you catch illnesses earlier, and also a lot of mental illnesses like depression are comorbid with other illnesses, so they make diabetes harder to treat, heart disease harder to recover from. So there's savings, but even more, I think, one of the things I'm most pleased about with collaborative care is it works across multiple groups of folks, including for people of color, for people living in poverty. And the reason I think it works so well for everybody is it embeds the care in primary care. So you don't have to come back. And so coming back is really hard if you are working a job, you can't get time off, you don't have easy access to transportation, you're in poverty. If you have concerns about whether the health system has your best interests in mind. There's a lot of concerns people have, but everybody does better if at the same appointment you get the help you need. So what they do with collaborative care is you show up at your primary care doc, and there's a screening that happens for everybody that you fill out yourself, because it only really works if you fill it out yourself, because otherwise you may not tell the truth or be less likely to. And then if that screening indicates you might have depression, anxiety, substance use disorder, then there's a behavioral health care manager on the team, just like and the behavioral health care manager comes in and she helps you with additional questions. She meets with you and the primary care doc. And then if you all are figuring out your treatment plan and you don't really know what to do, there's a psychiatric consultant, a psychiatrist who works on that team too, who can maybe not right at that time, but later that day can get in and consult and say, maybe we don't try medication. Maybe we should wait, or maybe we should try a different medication. And so that team works together, and it solves so many of the two big barriers that we have to care. One is we don't find that people have care. And the second thing is we don't keep people connected to care. So we might say, hey, you have depression, go fill your prescription, come back and see me in 3 weeks. And then the person never fills their prescription or comes back because they're depressed or because they're anxious. Like I have an anxiety disorder. So, I might not want to come back. I might be worried about what's going to happen. So what the care manager does is they call you and they check on you and they see, did you fill the prescription? And they kind of help say, well, can we do something? Well, come on, let's talk about your concerns on the phone. They really hold that person's hand during that initial phase of treatment when if you are on medication, it's probably not helping yet. So that's why it works so well. And the other cool thing is that basically every insurance company and Medicare currently pay for it, but very few providers have yet to deliver it. So we're in this kind of transition period. Does that kind of describe it? Okay.
Excellent. Yes. Thank you.
Yeah.
Lots and lots of opportunities still yet for collaborative care to expand. And, as you know, lots of evidence around it already. But while we're on the topic of different things that you discussed, curious to know if, what's the regulatory relief around telehealth services moving forward? Anything you can say about that?
Yeah. So it's really important. One of the few good things that came out of the pandemic was telehealth became a normal expectation. We could have done it before, but a lot of providers were unwilling. They hadn't really kind of gone through the inertia of shifting how they practice. And then, 30 days in March and April of 2020 changed the world. And so, we had clinics everywhere going from 5% telehealth to 100%, certainly during those initial months. And what we saw were so many cool things. So like productivity targets went through the roof. People were able to see people more because people didn't no show. If you got to drive across town, good chance you might not make it. Some chance. You just got to hop on Zoom, you're going to make it. Also, we saw rural access increase. All of a sudden, communities that have no therapists had access to the large university hubs and other things were around. So that was fantastic. But then, do those laws stick around? So there's sort of two sets of regulations that govern access to telehealth, and a lot of them are at the state level. And so that's state by state. And I'll tell you, in Texas, where I'm based, we basically said everything we want to have stick. And in fact, Texas even joined the compact for being able to have physicians practice across state lines, which we're the biggest state that's done that. We'd like New York and California and other states to do that too, so we could all share our workforces. And really too, like I've got children in college, right? And so when they go to college, well, now they live in another state, right? So they have to change their doctors, whether it's a mental health doctor or any other doctor. I mean, those laws are problematic. But that depends on states. Then the federal government, a lot of things were done too. Like one of my favorite ones was in Medicare, allowing not just telehealth, but audio only telehealth. Because for mental health, audio only works great. I mean, not for everything, but for a lot of things. And it also works better than nothing. Like if you live in a community and you don't have access to broadband, either because of your financial situation or it's not available in your community, using that phone thing can really be a lifesaver. So Medicare, liberalized its laws that way. And our sense is that everyone in Congress wants to continue that. I mean, those laws have not been fully enacted yet, but we're very optimistic. And I think everybody, who's listening to this, if you have folks you talk to, even if you think telehealth isn't the best thing in the world, it's a good thing, and it should stay. And I'll add, Salome, that that collaborative care model I was talking about, that could be done with telehealth. Like you don't have to have that care manager in the office with the doctor. The doctor could have them on a screen, just like we are, and like pull Andy up and have Andy help. And so it's just so it's both good for direct to consumer, direct to the patient, but also for like between collaborating team members being able to work together. So we're optimistic, but we're not done yet. And by the way, if you're in a state that's not Texas, go ahead and shame the people in your state and say, well, Texas did it. So I don't know what your problem is. So you go ahead and use that, and we're happy to share that info with you.
Fabulous. Really good advice. So we've got payers in the audience. How can payers, third-party administrators, how can they take action to address some of the challenges you've been talking about?
Yeah. Well, one of the things that I talked about was parity, and, they're in the target, right? They're the ones being reviewed. And I think one thing that would be great would be if they partnered together and with organizations like ours. We're part of a collaborative called the Path Forward for Mental Health and Substance Use, where we're really trying to say, look, we can't just do this by paying therapists more or changing how we administer. I mean, those might be necessary. A lot of times they are, but we really have to make this shift to primary care. So remember I talked earlier about how insurance companies usually have a separate division for behavioral health. They really need to build the communication and quit trying to solve this problem just with a behavioral health specialist. They need to talk to the primary care side of the house and work together. And the problem is a lot of the people in the behavioral health side don't know this because they're behavioral health specialists. So they're thinking, well, we need more people like me. We need more therapists. And they do cool things like we need peers. We need, alternative models for developing. That's all really good. But if they don't reach across and talk to the primary care side of the house, then they're like, not only do they have one hand tied behind their back, I would say they have like 9 fingers tied behind their back, because primary care, if they did that, collaborative care allows you to get 3.5 times as much help out of every psychiatrist if they're inside collaborative care versus if they're practicing in a specialty practice. And a psychiatrist can do both. They can spend half their time in specialty care and half their time collaborative care. So the insurance companies really have to factor that in, and it's cool that they're doing telehealth. It's cool they're doing a lot of other things, that they've got partners helping them with that in their network. But if they don't get across the primary care side, that's one. And there's another one, but does that make sense before I tell you the other one? Yeah. Okay. So the other one that I think they really need to do is that they need to start thinking about children more. So right now, we know, and we've only known this for about, I mean, some people have known this for longer, but as a field, I'd say we've only known this for about 10 years, that 50% of all mental illnesses begin by the time you're 14. It's like my anxiety disorder started when I was a little kid, you know, I mean, like a toddler, probably had it. I was probably wired that way from the time I got out of the womb. I didn't get help till I was in my 20s with that. And so the average time is 8 to 10 years that people wait. And it's probably longer. Like if we look at sort of some of the precursors for depression, even for psychosis, it's years. And a lot of times too, things like they're real severe, like psychosis, when you're little, you will have other things like anxiety or things that maybe they aren't a psychosis, but your brain is, has its own way of interacting. It's a little different from other folks. So if we're catching these things when we're children, then we can help parents figure out how to be better parents. My mom, thank goodness, had some good resources for figuring out how to raise a very anxious, child. Not every parent has access to those. So we'll help the parents get access to that, help them be good partners to their children. And then also recognize that 75% of these illnesses begin before your brain stops developing when you're 25. So that means college age, that transition when you're coming off your parents' insurance and on to your own insurance, or when let's say you're in the Medicaid system and you're transitioning from the child system to adult. A lot of things happen in that adult transition. And that's exactly the time mental illnesses tend to get more severe. And also some of the more severe ones emerge. So we really need to start thinking more about kids and not waiting until somebody's, 40 and then finally, they're suicidal, and then we get help then. I mean, we wait for crises. So that's the second thing. I've got a third one. Can I tell you the third one? Okay. So the third one is that they really need to crack down on accountability with us. Because and I'm talking about me as a clinical psychologist, we have not really been accountable in a clear way for people getting better. And what I mean by that is symptoms. We don't track, most therapists, most specialists, over 80% do not use regular standardized ways to measure symptoms as part of their practice. It's an art, or they wing it. In fact, when I was trained in the 90s, that's what they told us to do. They said, well, don't, trust those things too well. Well, that was a bad idea then, but it's really bad now, because like the PHQ-9, that has 80 to 90% reliability. And if you have the kind of relationship where you'll tell the truth, then it's almost 100%. The reason it doesn't have 100% reliability is because sometimes people don't want to tell the truth. They're like a pilot, and they know they're going to put on administrative leave. They can't fly if they're depressed. We want the pilot to tell us so we can help the pilot get over their depression. But so that's called measurement-based care. And really, insurance companies need to start cracking down on us. I mean, come on, like crack down on us. That's what I want them to do. And and if we're not providing accountability on symptoms, why would you pay us for that? Like, why would you pay a doctor treating hypertension who never took a person's blood pressure? I mean, why would you do that? And blood pressure is not all that reliable. Like for me, like when I go to the doctor, if they take my blood pressure right away, it's like off the roof, because I've been texting and driving, and I'm a type A guy. I got to sit there for 10 minutes. And if I sit there for 10 minutes and they take it again, then I'm like, I look great. So measurement is a tricky thing, and we have to get therapists to do that more. So I think those three things: think across the aisle to primary care, think about kids more, and then make us do measurement-based care. Like, quit paying us for like art. Like it's not helping anybody.
Right. Wow. And texting and driving, but not at the same time.
No, I texted. I don't know. I texted Dendro. Good point.
Just making sure.
Yes.
Yeah. So this is the things you're talking about. It's definitely been a theme throughout the conference. Really implementing measurement-based care. But also for the providers in the audience, I think there also needs to be more awareness that collaborative care is reimbursed. Like there are actual pathways already, correct?
Absolutely, yeah. And I think, basically, if you're an adult practice and with a commercial insured market, it's almost all of your payers will cover it. The problem is Medicaid. So not every Medicaid program covers this yet. And I'll use that line I did earlier. Texas does. Texas added it last year. And you may be familiar with the fact that Texas is not exactly the most enthusiastic state about Medicaid in terms of our engagement with Medicaid. We haven't done expansion yet. I don't know if we ever will. But we added collaborative care because it works so well and it's cost effective. So a lot of states are in the transition now with that. We're just starting a analysis with the Commonwealth Fund to partner with some folks to see what other strategies. So we do have to get Medicaid. And the reason that's so important, Salome, is because most large children's providers, so like our children's hospitals, they see lots of children, including lots of children with Medicaid. So they can't really have a two standard system. Like they can't come in and like my kids have private insurance, so they can't give my kids access to collaborative care, but not give my friend who's on Medicaid, give his kids access to the same thing. So it's a really big deal in the children's world to have Medicaid added. So if you're in a state where Medicaid's added it, then there's lots of like we help people make that conversion. There's companies like Concert and Mindula, Neuroflow. There's a lot of great organizations out there that can help you figure out how to both be reimbursed for it, but also you have to change your workflows. You have to staff up a little differently. You can't just, it's just not business as usual. So it's not hard, but it does take some focused effort. And a lot of times too, there's some startup costs. Like you got to hire somebody before they get fully paid. So one thing we've been doing is really engaging philanthropy and saying, hey, philanthropy, this is an opportunity for you if you want to help providers in your system get ahead, help them implement this. We're doing a really cool thing in the Panhandle of Texas with the Amarillo Area Foundation to do that. And it's a neat approach. And we're trying, Soulmate, to get the federal government to also do some stuff there. Congresswoman Fletcher from Texas and Herrera Butler from Washington State came together last fall to author HR 5218, which would give technical assistance and startup grants to primary care practices implementing collaborative care. And that's going through Congress right now. And, we're very enthusiastic. And we're also really believe they could also support other models like primary care behavioral health, which doesn't have as much evidence as collaborative care, but has some real promise. And a lot of people like that model. So we think Congress really needs to put some serious emphasis behind that. The RAND Corporation, when they did their analysis last year, said that basically put out a recommendation that we do something similar to what we did with electronic health records, where we mount a national effort over 3 or 4 years to get every health system to implement them, give them the startup, hold them accountable, try to help them with that. So, and if we did that, it's not going to cost that much. It's like probably less than $1 billion to retool the entire country, which is a lot of money, but not compared to, we're spending way more than that on other stuff. So that's, I think, where we go in terms of thinking about that. If you're in a practice thinking about how do we get some help from the federal government to you, how do we maybe get you some help from philanthropists to help you, because you are going to have some startup costs, and we'd like to make it as easy for you as possible.
These are all really great developments. I have so many more questions, but of course, time flies by so quickly. Andy, if I could ask you one last question. We've got a lot of digital health tech companies in the audience. What role can they play?
Yeah, well, you're all helping make this transition because because of the digital platform, because of the ways you're bringing about this, you can build all this in from the beginning. So like all that the digital companies we work with do measurement-based care. So if you have not built measurement-based care, and by that, I don't mean you're like AI-based, we're going to use machine learning to go into your records and really figure out things, or we're going to use your phone to figure out, how you are. I'm talking about like the PHQ-9, like ask people, and it's extremely reliable. So do all that other fancy stuff too, but do basic plain old measurement-based care, both because it works, but also because it'll help you communicate to the brick and mortar folks who are still using those things. So that's number one. Number two is push into that kid space. Like if you're only doing adults right now, stop. Like we have a youth mental health crisis. Go into the kid space. And that means working with parents. It's a little bit more complicated. And I don't just mean parents, caregivers, family, like the whole, family around that individual. And then the third thing I would say is really partner with the bricks and mortar folks. I mean, I think as long as y'all are a standalone organization and you're not getting integrated in, and that includes integration into primary care. Like to me, the digital health company of the future, the ones that are going to survive and be successful in this environment, are going to do telehealth, do regular telehealth and measurement-based care, but they're also going to get out front with prevention and engage patients in their own kind of lived experience in self-help and chat and all that kind of stuff. And they're going to be integrated into primary care so they can get help to people and transition them out faster.
Great advice. Thank you so much. Really appreciate your time as always. Thanks so much for sharing with us.
Thank you, Salome. Thanks so much for what you do. I love this conference and love how you bring folks together around this. Thanks for including us.